Okay.
The green room isn't even green.
Hello and welcome to our third talk of the morning at the patient section of VTE Dublin, all about blood clots. Dr. Barry Kevane is going to talk to us about cancer-associated thrombosis. Dr. Kevane is a consultant haematologist in the Mater Hospital Dublin. He's the chair of Ireland East Hospital Group VTE Working Group and a member of the Conway Sphere Research Group. He is currently researching COVID-19 and thrombosis. Dr. Kevane has been an avid supporter of Thrombosis Ireland, volunteering his time and expertise to help us raise much needed awareness. He will talk to us today about cancer-associated thrombosis. Thank you, Dr. Kevane.
Thanks, Anne-Marie, for the invitation and the introduction. Today, the topic of my talk, as you pointed out, is cancer-associated thrombosis. We are becoming increasingly aware, I think, that thrombosis is a major complication not only of cancer, but also of cancer therapy. And the treatment and prevention of cancer-associated thrombosis is one of the most challenging things which we encounter in our clinical practice as haematologists. So in today's talk, at the start, I'm going to speak briefly about normal blood clotting, moving on then to the mechanisms underlying abnormal blood clotting in the setting of cancer, and then I will talk about the prevention and treatment of cancer-associated thrombosis, and I'll finish up with some information on new developments in the field. So firstly, I suppose it's important to remember, of course, that not all blood clotting is abnormal, and in fact, activation of blood clotting and blood clot formation is, of course, a natural response to injury, which is designed to prevent bleeding and to support wound healing. But under normal circumstances and in healthy individuals, this is a highly regulated and tightly controlled process. Within the circulating blood, there are distinct pro-clotting and anti-clotting factors which are constantly opposing each other, but which are usually tightly balanced against each other in order to promote normal blood flow. And so in a normal, well-balanced scenario, there is sufficient baseline activity in the pro-clotting forces in order to prevent spontaneous or abnormal bleeding or bruising, but there's also enough activity in the anti-clotting forces to ensure that we don't get too much clot formation, or that clots don't form spontaneously or block blood vessels, which, as we know, is a form of thrombosis which can be potentially life-threatening. Examples of some of the pro-clotting elements which are present in our circulating blood include things like platelets, which, as we know, are very important pro-clotting blood cells. And examples of some of the anti-clotting forces which are present in our blood are things like protein C and protein S, which help to dampen down abnormal clot formation. If the balance in these two opposing factors of the anticoagulant forces and the procoagulant forces becomes skewed, favouring the activity of procoagulant forces, we get an increased activity in pro-clotting forces, leading to the formation of a blood clot within the blood vessel, which can take the form of a DVT or a PE, and as we know, this can be a potentially life-threatening event. There are many, I suppose, external forces which can affect this very tight balance between our anti-clotting and pro-clotting forces in the circulating blood, and these include things such as pregnancy, limb fracture, prolonged immobilization, major surgery, long-haul flights. And any of these risk factors or external factors can affect this balance in our blood clotting system. So, for example, if we look specifically, say, at pregnancy, we know that one of the things which happens in pregnancy is that we get increased levels of certain pregnancy-specific hormones, such as estrogen. Estrogen, in turn, can increase the production of some clotting proteins in the liver, such as factor VIII, and other clotting proteins, such as von Willebrand factor, and in turn, having high levels of these in the circulating blood, and in a pregnant woman, the levels of these proteins can be 2 or 3 times higher than they normally would be. This can increase the power of the pro-clotting forces, shifting the balance and leading to activation of uncontrolled blood clotting, leading to the form of a blood clot. And this is just one way in which external forces can drive abnormal clotting in our blood. So what do we know about how blood clotting becomes activated in cancer? Well, I suppose the first thing to realise is that clotting in cancer is really complex and highly variable between individuals. So clotting in any one patient is not the same because there are so many different factors that can be at play, particularly in the context of active cancer. We do know, however, that one of the most important ways that cancer is able to activate blood clotting is through the release of certain harmful substances directly from the tumour, which then enter the circulating blood, and these harmful substances can then interact with our normal blood cells, causing them to become activated and to form a blood clot. This is one of the most important and one of the most well characterised ways that cancer causes blood clots, a direct effect of the tumour cells themselves releasing pro-clotting factors into the circulating blood. And I've used the example here of a lung tumour, but of course this applies to could apply to any type of tumour. The complexity, though, of clotting risk for people with cancer does not end with the tumour itself, and in fact there are multiple other, I suppose, categories of factors which can impact on your overall risk of developing a blood clot if you have cancer. So obviously there is the tumour-related factors, treatment-related factors, and then factors relating to the person themselves that may be pre-existing and may not be necessarily linked directly to cancer. So if we go back again to the tumour-related factors, so what are the things specific to the tumour that can increase your risk of clotting? So one of the most important things is probably where the tumour is or what type of tumour you have. So we know that certain tumours from certain organs release more pro-clotting substances into the blood than others. So a good example of this is pancreatic cancer. We know that people who have pancreatic cancer have higher risk of blood clotting, and this is largely because pancreatic cells themselves are really good at turning on blood clotting. The cells themselves, they get released into circulation, can turn on blood clotting, but we also know the tumours in the pancreas release a lot of these highly pro-clotting substances into the blood. In contrast to that, we know that there are other tumours which are less high risk. So, for example, there are certain types of, say, breast cancers, which, while there's still may be associated with some risk of clotting, the risk is much, much lower than that which you might see with pancreatic cancer. So there is huge variability even within the type of tumour a person may have in terms of what kind of risk that will give them. The other important tumour factor to bear in mind is the stage of the tumour or how much tumour is present in the body. So in general, people who have a large bulk of tumour present in an organ or where the tumour is spread to a secondary site will have more risk of clotting because there is more, I suppose, tumour there to drive clotting. In contrast to that, someone who has a very small tumour that's limited to a single site would be expected to have a much lower risk of developing a clot. Similarly, the grade of tumour is important. So people who have high-grade aggressive tumours generally are at higher risk of clotting, whereas people with lower-grade tumours tend to have a lower risk. And the other thing, I suppose, is the time since diagnosis. So often when people develop blood clots associated with cancer, they tend to happen quite early on in the journey of their illness. And that's probably because at the early stages of the disease, you haven't yet received any treatment for your cancer, and so there's a lot of cancer there that can potentially drive clotting. So, for example, to summarise that, I suppose, the risk that a person might have for clotting would be much higher if they had, say, an aggressive high-grade pancreatic tumour that had spread to other sites, in contrast to someone who might have a very localised, low-grade breast tumour that hasn't spread at all. So there's huge variability there in terms of how much risk then those two different patients might be at from a clotting point of view. The other thing then, to the next category of, I suppose, of things are the treatment-related factors. So we know obviously that chemotherapy is really important and can cure cancer, but we also know that chemotherapy, or certain types of chemotherapy, can at least temporarily increase the risk of developing a blood clot. And again, this is largely sort of an individual thing and depends on the type of chemo the person is getting. So again, to give an example, there are certain types of platinum-based chemotherapy drugs, such as cisplatin, which is a drug that's often used to treat lung tumours, and that drug is known to be associated with a reasonably high risk of developing a blood clot. In contrast, some patients with lymphomas are treated with immunotherapies like rituximab, which in isolation would not be considered to be, a drug that causes a lot of clotting. So huge variability again within the type of therapy the patient is getting in terms of the type of risk that treatment is giving them. Some patients with cancer obviously need to have surgery, and again, this is great in that surgery can be curative, but we know that even outside of cancer, surgery is a major risk factor for thrombosis. And so if a patient has cancer, active cancer, and has surgery, we know that their risk is even more important again. As I'm sure Dr. Ewens explained in great detail in the last talk, admission to hospital is a huge risk factor for developing thrombosis for any patient. But again, if you have cancer, which comes with its own increased risk, and you combine that with hospital admission for treatment, then again, that's adding to your risk. And one of the other things that's really important, I suppose, from a point of view of clotting risk that's associated with therapy is the presence of a line, such as a central line or a porta cath or a PICC line. Again, these lines are great, they're really important for administration of treatment, but they are associated with the risk of clotting, so it's really important that we're aware of that. So again, it's about looking at the patient as a whole, and so looking, for example, well, what type of tumours does this person have? How advanced is it? Is it a high grade or low grade? What kind of treatment have they receiving? Have they had surgery? Are they admitted to hospital? Do they have a PICC line in place? So all of these things need to be taken together when looking at someone's risk of developing a clot from a tumour. And then I suppose the last category of risk factors are the patient-specific or the individual-specific risk factors. And these are usually things which really precede the cancer diagnosis. So for example, a person might have had a history of a prior unprovoked blood clot, or they might have a family history of blood clotting. And then if that person goes on to develop a tumour, then the risk associated with their previous history probably becomes more relevant, or at least it combines with the other tumour factors and the treatment factors. Other things to bear in mind in this scenario would be whether the person has obesity, whether they're a heavy smoker, or whether there are other illnesses present that might contribute to risk. So really, when we talk about risk assessment, that's really important when we look at the population of people with cancer, because of the way that there is so much variability in all of these categories of risk factors that can lead to that person's overall risk being either high, low, or intermediate. So I suppose the question then is thrombosis a significant problem for patients with cancer? And the answer to that is absolutely it is. We know from very good data that up to 20% of people with a cancer diagnosis will ultimately develop a thrombosis at some point over the course of their illness. We also know that the risk of getting a blood clot is 5 times higher among the cancer population than it is in the general population. So that's absolutely huge. And the other thing, which is quite sobering, I think, for us to see these figures, but we know that while the majority of patients with a cancer diagnosis who do not survive usually die as a result of progression of the cancer itself, we know that apart from cancer progression, thrombosis is the leading cause of death among people with a cancer diagnosis. People often think that infections or those kind of complications are possibly more important. We know now actually that thrombosis is at least as important and probably a higher cause of mortality among patients with cancer than infections, and it is the second leading cause of death in this population, bar of course progression of the underlying disease itself. So really the importance of thrombosis among the population of people with cancer cannot be overstated. Therefore, we really need to focus on making sure that we have adequate treatment and prevention strategies for thrombosis among people who are affected with a cancer diagnosis. And what's really important is that we're able to identify patients who are at high risk. And I suppose that's really important, because I guess there are certain precautions that we can take to try and reduce an individual's risk. So that's the good news, I guess, is that while cancer is associated with an increased risk of thrombosis, there are definite ways of addressing that or reducing that risk. So we're going to talk a bit on prevention of cancer-associated thrombosis now. So I guess there are two, I suppose, big things to bear in mind when it comes to raising awareness, and this is probably the most important thing really when we talk about reducing risk of thrombosis in cancer. And I would say the most important thing is that we raise awareness not just among patients and their families and their carers, but also among healthcare professionals, because as I mentioned in the previous slides, there's often this misconception that thrombosis may not be a massive problem in cancer and that potentially things like infections are more important. We know actually that thrombosis is a really huge problem in cancer, so it's really important when we talk about reducing thrombotic risk in cancer patients that we raise awareness of the problem among healthcare professionals to ensure that patients are being properly risk assessed and that they're being prescribed anticoagulant drugs if appropriate in order to address their risk. And of course, when we talk about awareness, it is also important to also focus on the patient and their family and carers. And we should always make efforts to encourage things which might also contribute to reducing risk of thrombosis, which include things like, encouraging good mobility, encouraging weight loss if possible, and obviously if applicable in a patient who's overweight, and encouraging, good general health measures such as stopping smoking. It's important, I suppose, as well, to be aware of when we talk about the whole concept of awareness of clotting risk, that we realise that, okay, despite all our best efforts, not all clots are preventable. But while not all clots are preventable, the vast majority are treatable. And so when we talk about education and awareness of patients and healthcare professionals and families, the other thing that we have to be absolutely sure of is that we're educating people appropriately and sufficiently so that they're aware of the signs and symptoms of blood clots, and most importantly that they're aware of the absolute urgent need to seek emergency medical attention in the event of symptoms of blood clots developing, as this might be life-saving. And I'm sure you've all heard the symptom list already today, but just to go over it again, it's really important that we recognise that symptoms of pulmonary embolism include things like chest pain, cough, breathlessness, coughing up blood, and also sudden collapse, which I haven't on that list there, but that's also an unexplained, faint or collapse is certainly a potential cause or a potential sign of pulmonary embolism. And when we talk about DVTs in either the legs or the arms, the signs and symptoms that we often see are leg swelling, pain, red discoloration of the skin, increased skin temperature, and particularly, I suppose, people who have PICC lines, who develop pain and swelling of the arm with the PICC line, where the PICC line is. That could be an infection, but it also could be a blood clot. And I would say most often when people with PICC lines have arm swelling, it's more likely to be a blood clot in my view than an infection in most cases. So it's really important that we're aware of all of these signs and symptoms and that we seek emergency treatment. And we're really delighted to have been involved with Anne-Marie and the team in Thrombosis Ireland in rolling out the blood clot alert card here in the Mater and encouraging its use across the R&D hospital group as well. So as you probably are all aware, this was an initiative driven by Anne-Marie, which is now also being driven by the HSE, and all hospitals in Ireland are supposed to administer these blood clot alert cards to all patients on discharge from hospital to ensure that they're aware of the signs and symptoms of thrombosis. And this is even more important in the cancer population, and certainly here in this hospital we are now driving I suppose an initiative to make sure that when patients are being educated about chemotherapy and risk of infection and that, they're also being educated about blood clotting risk and that they receive these cards as well. So just to highlight this point again, who needs to be educated about thrombosis risk? So it's not just the patients themselves, it's everyone involved, their carers, family members and healthcare professionals. And knowledge of the risk of clotting and the signs and symptoms can be life-saving. This is really important in the context of cancer, where we know blood clotting can be a huge cause of death, which is potentially preventable in many cases. I suppose as we often think about anticoagulant medicines such as the heparin injections as being important in reducing clotting risk or preventing blood clots in cancer, and that's certainly true, and we do consider using these medicines in certain high-risk patients to reduce their risk. But it's really important that we always bear in mind the patient's individual bleeding risk. And so, as I was talking, I suppose at the start, we talked a lot about how the balance in the circulating blood can be shifted towards increased activity of pro-clotting factors in the context of things like, obviously surgery and cancer and all that. But it's important that we also remember that if you give someone anti-clotting medicines, that shifts the balance in the opposite direction and increases the risk potentially of bleeding. So there's always a risk of major bleeding when we give people anti-clotting medicines, but we also know that patients with cancer who also obviously have a higher risk of blood clotting than the general population. They also have a higher risk of having major bleeding when they're exposed to anticoagulant drugs. So really, when it comes to the prevention of blood clots and cancer, we have to remember that the anticoagulant medicines aren't always the right answer for everyone. They are the right answer for certain people, but not for everyone. And the number one intervention really is being aware of the risk, knowing what to do in the event of symptoms, and taking general measures to try and reduce your risk, such as things like maintaining good general health, stopping smoking, that kind of thing. So I suppose, how do we decide who are the high-risk patients where we might consider anticoagulant medicines? So as I mentioned at the start, there are a couple of features that we know are associated with high clotting risk. One of the things is the size of the cancer, or what type of cancer the person has. So this figure here is demonstrating the cumulative risk of blood clotting that occurs over time in people with different types of cancer. So at the top of the list there is pancreatic cancer. So we see this all the time. We know that patients with pancreatic tumours tend to have a much higher risk of having blood clots than, say, someone who has a cancer that's listed at the bottom of the list there, like kidney or prostate. So this is one of the things that we consider when we're risk assessing an individual person as to what their risk is and whether or not they might need anticoagulant treatment versus, you know, just the more conservative approach with advice and education about reducing their existing risk factors. Another thing that we look at is where the patient is in their journey, I suppose, of treatment. And that's because we know that the clotting risk is highest at a time where your cancer is most active. So if you see on this graph here, it's showing how clotting risk varies over time. So the bottom line here, these first dotted lines, the risk of the general population. The second dotted line here at about 4 is the risk of cancer risk of clotting in the cancer population, and this line here is supposed showing how that might change for an individual during their own kind of individual journey. So when someone is diagnosed with cancer initially, they have a certain amount of active cancer there and have not yet received any treatment. So they have quite a lot of active cancer. So as a result, their risk of having a blood clot would be considered to be quite high at the time of the initial diagnosis. When that person gets admitted to hospital and starts to receive treatment, the risk goes up even more. And that's because we already know that being admitted to hospital is a risk factor for blood clotting, as Dr. Ewens would have explained, and also administration of chemotherapy, having surgery, all of these things increase your risk. So during that initial phase of the initial diagnosis, initial admission to hospital for treatment or surgery, the risk of clotting is probably at its highest here. This is why we see most blood clots in the early stages of disease. Then as a person is receiving their chemotherapy and their cancer is becoming under control, and as the cancer is disappearing, their risk of clotting starts to reduce. And then once the person is in a stable remission and is not receiving any therapy, their risk of clotting is very much reduced. Not quite to the same level as the general population, but is still quite low. If the cancer was to unfortunately return and start to grow again, then obviously your clotting risk would also start to grow again. And as patients as a patient might approach end of life where their tumour is established and not being treated any further, because there would also be quite a lot of tumour there at that point also, the clotting risk would also be quite high there. So also quite a high risk of clotting towards the end of life phase. We also look at the tumour grade, as I mentioned at the start. So the grade of the tumour is something that the pathologist will tell us when they look at it under the microscopes. There are certain things they can tell from looking at the cells if they're aggressive or not. And so, as I say, people with high-grade tumours have high risk of clotting versus people with low-grade tumours have low risk of clotting. And this is something we might see, for example, in a lymphoma, where someone with a high-grade tumour would be expected to have a higher risk of clotting than someone with a lower-grade lymphoma. So I suppose it's really important then to consider that not all patients with cancer will be at high risk of thrombosis all of the time, but most people will be at high risk some of the time. And so we need strategies to identify patients. Number one, to identify the high risk patients, but also to identify people who are usually low risk, but who may temporarily become a high risk for other reasons. And this is important because it allows us to target the anticoagulant medicines, because as I mentioned, these anticoagulant medicines have their own risks. So who do we give anti-clotting medicines to? So in general, if any patient with cancer is admitted to hospital for, bar maybe a day admission, they need to receive anti-clotting medicines in the vast majority of cases, unless they're at risk of bleeding for some reason. Like, for example, some people will have very low blood counts after chemotherapy, so mightn't be able to tolerate the clotting medicines. Generally, when a patient with cancer has major abdominal surgery, we usually consider recommending a kind of a more extended period of blood clotting medicines to cover their high risk phase. Again, that depends on the individual and what bleeding risk factors they might have. If someone has a very high risk of bleeding, obviously you will not do this. I suppose what patients with myeloma, which is a specific form of blood cancer, can be at significantly high risk of clotting, particularly if they're receiving treatment with drugs which are called immunomodulatory agents, such as flutamide, lenalidomide, and pomalidomide, in combination with steroids. And so this is one of the few groups of patients who would be recommended to receive some form of anti-clotting or antiplatelet therapy from the outset, and even as outpatients. But in general, when we talk about people who are receiving cancer therapy as outpatients, it's for the vast majority of these people, the risk of anti-clotting medicines probably exceeds any benefit that they might derive from it because of the potential risk of bleeding. But obviously that is dependent on the fact of the patient being educated on the signs and symptoms of blood clotting, so that in the event of them having a blood clot, they attend immediately for assessment. What do we use to prevent thrombosis in cancer? So I suppose the most commonly used option is the heparin injection. So the heparin injections we have in Ireland are iron hepatoxane. We can also sometimes consider the use of aspirin, particularly in that myeloma group who are receiving outpatient chemotherapy. And there is some emerging evidence, although early evidence, I suppose, for the use of low-dose DOACS for the prevention of thrombosis in cancer. So current international guidelines recommend against the use of routine anti-clotting medicines in all outpatients receiving cancer, or all outpatient patients receiving chemotherapy. And that's because a lot of these people probably are at low risk. Because if you're someone who is, a few months into your chemotherapy and you're well and your cancer's under control, your risk probably isn't high enough to justify the potential risk of major bleeding that would be associated with going on a blood thinning medicine. But there are high rates of thrombosis in certain subgroups of patients with cancer, and so guidelines would recommend anti-clotting medicines in those groups, and that would include, as I said, the myeloma cohort and some patients with certain forms of advanced pancreatic cancer who are receiving anti-clotting or who are receiving chemotherapy. How do we identify these patients? It can be really tricky. One of the things which people may have heard about is the Khorana score, and this is a risk assessment tool which was developed to try and identify patients at high risk based on certain characteristics. So these include things like the patient's body mass index, so their weight and their height, and then there are certain blood test results looking at their blood counts. And probably the most important thing that this scoring tool looks at is the site of disease. So people with stomach or pancreatic cancer score highly, as opposed to some of the other tumour types. And then based on the person's score, you can estimate what their risk of developing a blood clot while on cancer therapy in the next 6 months. And this is a scoring system which is good for predicting clotting risk. It hasn't really been validated, I suppose, for identifying patients who definitely will benefit from treatment with anti-clotting medicine. So there is some, I suppose, ongoing debate in that regard. But there are certain people, certain oncologists who will use this scoring model and may apply it to a patient who they may feel may be at high risk. For example, it may be someone who has existing risk factors for thrombosis, like a previous history of a blood clot. So then moving on to the treatment of cancer-associated thrombosis. So I guess the first question to ask ourselves is treating blood clots in patients with cancer different to treating patients without cancer? And it absolutely is. Our general approach is that we tend to use either heparin injections or the newer DOACS. But unlike other types of blood clots in the non-cancer population, our minimum duration of treatment is 6 months. But in addition to that, we would tend to continue anticoagulant therapy as long as there is active cancer on board. And that is because, as I outlined in some of the earlier slides, when there's active tumour or active cancer in the body, your clotting risk is high, and that's always the case. If you manage to get your cancer into remission, then at that stage we can certainly look at stopping the anti-clotting treatment. Difficult to justify stopping blood thinners unless your risk of bleeding is very high. And we also tend to consider continuing anti-clotting treatment for the duration that the person is on active therapy, because, as I mentioned again at the start, there are some chemotherapies which increase risk of clotting. So if you have a blood clot and you've had your 6 months of treatment, but you're still receiving anti-cancer therapy, which may also increase your risk of clotting, we would generally tend to continue with the blood clotting medicines during that period of time. I suppose heparin was our drug of choice for years, and that was because there was a very important trial published in the early 2000s called the Clot study, and this showed that heparin was much more effective than warfarin in the cancer population. So there was 50% fewer clots happening in patients with cancer who were treated with the heparin injections instead of warfarin. The benefits of heparin, I suppose, is that they're more effective than warfarin for sure. They're similarly as effective as DOACS, but they probably have a lower risk of bleeding, specifically for some higher risk bleeding tumours. Because heparins are given as an injection, we don't necessarily have to worry about them not being well absorbed from the gut or being affected by GI upset. And also because these are injected, they tend to not interact with chemotherapy. So heparins are really reliable, really safe and effective drugs in the treatment of cancer-associated thrombosis, but obviously the big drawback is that they're administered by a daily injection. DOACS have only recently been shown to be effective in the cancer thrombosis population. So we know that DOACS are as effective as heparin in reducing the risk of developing another clot, and the other pro is that obviously they're very easy to administer. The cons, I suppose, is that they are higher risk of bleeding associated with DOACS, particularly with people who have gut tumours. So if you have a stomach or esophageal tumour, the risk of bleeding is much higher with the DOAC than it would be with the heparin injections. The other thing, I suppose, is that these oral medicines can interact with chemotherapy and certain antibiotics, so that can sometimes be a problem. And if someone has stomach upset or if their gut isn't functioning properly as a consequence of their chemotherapy, they may not properly absorb their tablets. And also, unlike the heparins, it's very difficult to dose adjust a DOAC, because obviously these are fixed doses. So if someone has a fall in their platelet count, managing their anticoagulant therapy with a DOAC is much more difficult than it would be if they were taking heparin. But either option is now potentially on the table. Most, I think, hematologists would probably, if they have a patient who presents with a significant blood clot, would probably at least start with a heparin injection until things are stable. But I think we would usually try and move to tablets at an early stage, given the convenience. Line-associated thrombosis is obviously a very important topic, and it can be a major source of problems for patients with cancer. And these types of lines include things like PICC lines, portocath, central lines, and Hickman lines. So these are great, and they allow us to administer chemotherapy and also allow us to take bloods for blood sampling. But they certainly come with the risk of developing a blood clot. If someone has a blood clot associated with one of these lines, in general, we don't really need to pull the line, provided the line is functioning normally and isn't causing huge sort of problems like, and that isn't like threatening the circulation of the limb or anything like that. So for most people, it is safe to leave the line in place, provided you're anticoagulating that person. And so all of these patients would receive at least 3 months of anticoagulant therapy. But if the line stays in place, we would generally continue the anticoagulation beyond that until the line is removed. But every patient with a line-associated thrombosis would receive at least 3 months of therapy. So are there any new developments in cancer-associated thrombosis? I suppose the biggest thing recently has been our approach to direct oral anticoagulants. So these are the tablets, Apixaban, Rivaroxaban and Edoxaban. So up until a couple of years ago, we had no data supporting their use for the treatment of cancer-associated thrombosis, but we do have that data now. And so many patients with cancer-associated thrombosis will be treated with these tablets instead of the heparin injections. I guess I mentioned earlier the Khorana score and using that score to identify people who haven't had blood clots but who are at high risk of blood clots. And there has been a number of studies published that have looked at the use of using a low dose DOAC in order to prevent blood clots happening in the first place in patients who are at high risk, so people who have a score of 2 or higher using that scoring model. And I suppose the outcome from these trials has been, I suppose, positive but not definitive, in that there does appear to be possibly some benefit with these drugs in reducing clotting risk, but there hasn't really been shown any mortality benefit. So we've yet to see these drugs or this approach save lives. And of course, using these drugs or giving these drugs to patients does potentially increase risk of bleeding. And that was something which also came about in or was seen in those studies. So in some of the guidelines now, the international guidelines, particularly the American guidelines, they do suggest considering low-dose DOACs for patients with cancer who haven't had a blood clot or who are thought to be at high risk of developing future blood clot. But I think the jury is out in many places with respect to this practice. So while we definitely have good evidence for using DOACs to treat cancer-associated thrombosis, their use in the prevention of cancer-associated thrombosis has not yet been fully defined. So I suppose to summarize, thrombosis is a major complication of active cancer and is a leading cause of mortality in this population. Prevention of thrombosis is absolutely crucial, because we know that if a patient with cancer develops a thrombosis, that this is associated with shortened survival. The optimal prevention strategies have not yet been defined, although treatment with anti-clotting drugs is recommended to be considered in some high-risk patients receiving chemotherapy. But probably the most important thing is making sure that we adequately educate our patients, so that should a blood clot occur, they're aware of what to look out for and what to do, which is basically to seek out urgent medical attention. Treatment of thrombosis is challenging in this population due to the high rates of recurrence and high rates of bleeding on treatment, but thankfully we do have some new treatment options, and the direct oral anticoagulants in particular would probably represent a way of continuing treatment in the long term for a lot of people who can't tolerate injections. So that's the end of the talk, and I'd be happy to take any questions that Marie and Anne may have there.
That's brilliant. Thanks, Yvonne. That was really, really interesting. I suppose the first thing I'd say is that there's an information leaflet on cancer-acquired thrombosis on our website for anybody who'd like to download it. And there's also some posters that you can use and get printed for your clinics, that raises awareness about it. Our alert card is also on the website, available for download. And if anybody'd like to contact me, I'll give them the details of where to order it for their clinic. And it's also available in 17 languages. So I'd like to share with you as well something, a project that we were involved in last year, the patient voice in cancer research. And the feedback from cancer patients at this forum was that they didn't want us to be afraid to scare them, because they're already scared. So if you're thinking, oh, I don't want to give them more bad news by raising awareness about their thrombosis risk and the signs and the symptoms and further risks of thrombosis, it's a myth. They're terrified. And the only thing they pay attention to is anything that is put really strongly and frighteningly. So they don't want any of us to pussyfoot around. Would you agree with that, Barry?
I absolutely. I think that's a really important point to make. And I think that's probably goes to the core of why our own practice as healthcare professionals probably isn't up to scratch in every case when it comes to educating patients, because I think a lot of people would feel, okay, I've just given this person a really, maybe devastating bad news that they have a cancer diagnosis and they have to go through all this treatment. And the last thing I'm going to do is say, oh, by the way, thrombosis is a leading cause of death, and this is what can happen, and it's an emergency. And I think there's a huge reluctance to broach that. So I think that's really an important point that you've made there, actually, and that's something that we probably need to do more of in feeding back to our own staff when it comes to counselling patients around the time of a new diagnosis of cancer. I think it's really, really important. Yeah.
Another thing is that we discovered was like all cancer treatments and all stages of cancer treatment and types, whether it be surgery, treatment, recovery, whatever, is all planned. But when it comes to thrombosis, it's like as if they've been put into a washing machine. It's like if it hits them out of the blue and they haven't been warned, it's nearly the worst part of their whole experience, and that's the feedback we're getting. And I think that's why it's so important that thrombosis is a very big part of that initial information. Another thing that they fed back to us was that they'd like to be told a number of times. So they'd like to be told on the initial diagnosis. They'd also like to be told maybe when they come in for their first treatment or discussion about their treatment. They'd like to be told during their treatment. They want to be reminded until it gets embedded into their brain, because on hearing the risk factors and the fact that it is so preventable, but the fact that their cancer treatment will most likely cure them in many cases. And then out of the blue, this other thing, it's like the elephant in the room comes and gets them from behind. If they haven't been armed with the information to protect themselves, they've no chance. But if they've been armed with the information, then it's only another part of the treatment. It's another thing to watch for. It's another thing to be careful about, and they can protect themselves, so it's not as scary, and it won't hit them then out of the blue. And they were interesting findings and coming direct from the horse's mouth, from genuine cancer patients at this table with us. And I think it's really important to share that with all the medical staff listening. Really important. I don't have any other questions up on the group. I think that's it. Barry, I think that was really interesting, and you've covered absolutely everything. And if anybody has any questions that they think of after the fact, they're welcome to email us directly, and we'll forward them on to Dr. Kevane, who can come back to us on them. Is that okay? That's
perfect.
Brilliant.
Thank you.
Bye.
Bye.